All right, welcome y'all. Thank you for coming on a Saturday morning, midday. We're going to talk about arthritis. So the big thing that we really want to focus on is give you some helpful information. There's lots of myths, misconceptions about arthritis, but also how to actually manage it and also how to prevent it as well. So all about the topic of arthritis, quick introductions. So my name is Dustin Jones. I'm a physical therapist. I, along with this lovely gentleman over here, Jeff Musgrave, are working with StrongerLife. So StrongerLife is Lexington's community for people 55 and up, Lexington's fitness community. We operate out of this space, doing workouts every single day that are modifiable, scalable, so folks can get a good workout, but also get a sense of community and that shared struggle, and have a lot of fun as well. Sometimes we have fun. I'd say most of the time. Yeah. This has been a great community. Jeff and I, we have our background in geriatrics is the term in the medical realm, but working with older adults, and we have a passion for that because what we found is from our skill set and our training, we can make a greater impact with an older adult than, let's say, someone that's 18 years old or some collegiate athlete or whatever. A lot of people try and go into the field to work with those folks. Man, we love working with people 55 and up. Because we can really get some amazing results. So that's my background. This is Jeff. I'm going to give him this mic here. Cool.
Giving me the mic is a dangerous thing. We'll see how it goes. All right. So as Dustin said, I'm a PT as well, focused on older adults. So let's jump into this. Arthritis, right? That's what we're here for. So 2 topics we're going to cover today. 2 different kind of sections of this presentation is going to be what is arthritis? That'd be a good place to start, right? And then the second part is what can we do about it, right? So hopefully we can reduce some myths and misconceptions as we go along. Feel free to ask some questions along the way too. That makes it a little more fun. Believe it or not, I don't like to hear myself talk. I'd prefer to hear from you guys because everyone has an experience and a perspective that can really round out a presentation and understanding of this topic. So, here we go. Can anyone read this for me?
Can't exercise. I have bone-on-bone arthritis. False.
Great place to start the presentation. Okay, so starting with arthritis is just an umbrella term, okay, that represents kind of these 3 symptoms: pain, swelling, and stiffness. It's not just wear and tear. We hear that a lot, right? Oh, it's just wear and tear. You just used your joints too much. And we'll get into what type of use is good, how much use is good for your joints. But key factors for progression of arthritis: inflammation, body weight, previous injury. Not previous use, previous injury. Okay, so here we go. So these are some of the more common types of arthritis. Osteoarthritis, most everyone's probably heard of that one. Show of hands, who's heard of rheumatoid arthritis or has rheumatoid arthritis? Okay. How about ankylosing spondylitis? That's hard for a country boy to say. Yeah, okay. And then how about psoriatic arthritis? Yeah. So, and if you see by the show of hands, that would almost directly correlate to its prevalence, how you guys did. So osteoarthritis affects about 52 million people. Yes?
Wait, so on the previous slide, when you say key factors, you mean those are the things that are almost like determinants of people that are more likely to get arthritis?
Yeah, those could be predictive factors or could speed progression of arthritis. And we'll cover that a little more as we go along. Great point. So, arthritis, it's kind of like gray hair, kind of like gray hairs. It's a sign of aging. Unfortunately, what's happened is we've correlated signs of aging with the expectation of pain and limitation. But the studies don't say that. In this room, we could shoot x-rays of everyone's probably hips, knees, spine. 70% of us are going to show some type of degenerative change. But only about 20% of us will maybe have symptoms. So the correlation's not direct. Arthritis does not equal pain. Arthritis does not equal weakness necessarily. That link is a little too strongly correlated, but we should think about changes in joints on imaging more like gray hairs. Everyone's going to get them. That doesn't mean everyone has pain or limitation, okay? Osteoarthritis, 30 million in the US. 20% of the US population has some form of arthritis, at least if you're looking at imaging studies, okay? Most common joints affected: hips, knees, backs, hands, the dreaded DDD. Does anybody know what DDD is? Degenerative disc disease. Yeah, crushed it. Which is kind of a symptomatic description, really, based on imaging findings. Not really a great way to categorize. So we start looking at risk factors. There are risk factors that we can control, and there are ones we can't control. So far, we've not been able to stop the aging process. We can definitely impact the quality of aging, what aging looks like. We see a lot of variation. I've seen that in clinical practice. I've seen people walk in, get pushed in a wheelchair in their 40s, and I've seen people bouncing down the hall to get into my clinic in their 80s and 90s. But physiological age versus chronological age, but that's a whole different topic. That's a rabbit trail. But modifiable factors, our weight does impact progression of arthritis, especially osteoarthritis, and for two different reasons. There's the mechanical, the physics aspect. If you put more load on the joint, it's weight bearing. You can imagine there's going to be a little more shear force, a little more friction. It could speed up progression. They've said that 10 pounds can increase the wear on your joints at an impact level of 30 to 60%, just 10 pounds. So weight is a factor. There's a chemical component to that too. Stored fat actually releases inflammation. Inflammation is a key factor with arthritis that we covered earlier, but can actually speed the progression of wear of cartilage, which is thick connective tissue, that is actually the friction point of most of our joints. We've got a form of cartilage there so that everything slides and glides smoothly. Low muscle strength. Why would that matter? Yeah, our muscles are springs. They absorb force. They help control movement. If we've got weakness and we may not be controlling, if we've got a knee that's a hinge joint and we don't have good control of our hips, that can change the direction of force going through the joint that maybe it was or maybe it wasn't designed for. So great points there. Other chronic conditions, anything that has an inflammatory impact that causes more inflammation in the system can speed the changes to the joints and the joint surface. Previous injuries, not just use, but previous injuries and other chronic conditions. So there are some chronic conditions that are modifiable based on diet and activity that can be regulated with medications. There's some that we can't. Yes?
Do you know what qualifies as overweight? Do y'all use BMI or?
Ooh, I don't like BMI at all. That's not accurate. That's not something that we're currently tracking in our group. I think if you look at body composition, body fat percentage is going to be a much better indicator. We know muscle weighs a lot more, different body types, sizes, shapes. When I did my screening this last year, was categorized as overweight based on BMI.
Right.
Just weight, height, sliding scale. Yeah. If you're super tall or you're muscular, forget it. Yeah, that's a great point. Outdated system. So rheumatoid arthritis is an autoimmune disease, common in small joints, hands, wrists, feet, usually diagnosed between 40 to 60 years of age. Can impact other body systems, cardiovascular system, your eyes. Big common complaint, fatigue. Right? If our energy levels aren't up, I don't think that's really a distinguishing factor. We don't sleep enough, don't eat well, we're all going to be fatigued. I don't think that's helpful diagnostically necessarily. But autoimmune disease, what's that mean? Any thoughts?
Body attacks itself.
Yeah, exactly. The body's unfortunately identified your own tissues as invaders and have started to attack them. Whoop. Here we go. So similar factors here, family history, There is some genetic link there. Smoking, our weight as well. Environmental impacts, and this is kind of interesting. That's kind of a vague description, but just having some type of virus can actually trigger this to happen, or a long-term period of stress. Stress actually increases cortisol levels and inflammation in our body system, and if we're prone to this or we've got a genetic disposition, could actually teeter us over the edge into this being triggered. But still a lot we don't know about rheumatoid arthritis at this point. First line of treatment as far as medications, usually NSAIDs, non-steroidal anti-inflammatory drugs, okay, to reduce the inflammation. Getting a common theme here, right? And then methotrexate, which is a disease-modifying anti-rheumatic drug, and different biologics. So basically, this class of drug is just trying to identify different parts of the inflammatory cascade and take out one of the players, because it's a chain reaction. So there may be 6, 7, 8 steps, and we're going to identify this one. If we remove this player, then it doesn't continue, or this player. So people will respond differently to different medications. There's several out there in that category. Ankylosing spondylitis, a little more rare form compared to osteo and rheumatoid arthritis, usually diagnosed before the age of 40. It is characterized by this change in posture. And this is a little bit different. We've been talking about, rather than like axial skeleton or what we find at the midline, we've been talking more about peripheral joints like knees and ankles. But this attacks the spine more directly. Most of us, we've heard degenerative disc disease. We're talking about that same disc in between the vertebra. But in this case, it actually will fuse. Instead of being soft and squishy and allowing you to move, it'll actually calcify. And eventually, over time, the entire spine can fuse. So treating the inflammation is helpful from a symptomatic standpoint, but also the same class of drugs to reduce the inflammatory cascade. Corticosteroids, anti-inflammatory medications are helpful, but also movement. Movement is very helpful here, because if we keep our body moving through the available range of motion and work to correct our posture, we can actually, there's studies to show that we can slow the progression of that fusion and help maintain function longer. Psoriatic arthritis, another autoimmune disease, very similar to rheumatoid as far as its presentation. The big factor here is psoriasis. There's usually also psoriasis involved. Diagnostically, you can take a blood test. If you've got that similar presentation with psoriasis, but you don't have the rheumatoid factor identified for RA, then you may have psoriatic arthritis, usually diagnosed between 40. Exercise, once again, is key. Arthritis Foundation has done a lot of great work to put resources out there in current research that movement is really medicine for these conditions. Okay, so we've covered a little bit of arthritis. We're going to move into what can we do about it? The exciting part, because there is stuff we could do about it, or the presentation would just end now and we would all leave with our snacks, right?
All join StrongerLife.
Ah! I'll pay you later for that. Okay, so short term, I'm going to cover short term. Dustin's going to cover long term. These will be pretty similar to most of you if you've had any experience with arthritis or with physical therapy. Heat versus ice. Heat's a little bit better. If we're going to be moving, we're going to have a period of activity after we're treating pain, because it loosens up the joint, increases blood flow, makes it easier to move. Not a great idea to sit on ice for 20, 30 minutes and then go exercise, because it stiffens everything up, reduces your range of motion. It is great for reducing inflammation, reducing swelling. So after activity, or if you get some post-activity swelling and you've got some time to relax and chill, pun intended, you can throw some ice on, okay? So pain medications, we talked a lot about these different classes of NSAIDs, or non-steroidal anti-inflammatory drugs. One of the side effects of long-term use of these is gastric bleeding, which can be pretty serious. So it's one of those things, some people have non-modifiable chronic conditions where they need to be on these long-term. But if you're taking it as needed for a long period of time and that's your primary source of pain management, that could do some long-term damage that is not easily reversible. So just a good thing to be aware of. Stretching can be helpful, right? It can actually reduce your pain short term. Movement of any kind, whether exercise or stretching, can release fluid in between our joints. Most of our joints that move are synovial joints that we're talking about here. And when you move, it actually releases synovial fluid that lubricates the space between the joints and allows them to slide and glide a little bit better. You can think about it kind of like oil for your motor in your car. Ultrasound, acupuncture, e-stim. So these are all classic treatments that have been used for a long period of time with various levels of research. A lot of them have a heating impact or increased blood flow. Blood flow gives you a similar impact to what heat does. Verdict still out. One that I like to pick on is ultrasound. Anybody had ultrasound treatment before? Yeah, I have too. I liked it. I thought it was nice. Current research says the impact is the same whether it's plugged in or not. And it has a lot more to do with your belief of whether it will help you. There's more power now, not acupuncture, ultrasound. Different level of research for acupuncture and the impact. Pretty similar with manual therapy and some short-term TENS. I mean, heating impact, pretty similar to using heat, depending on the type of TENS that you use. So, cryotherapy, similar impact to ice. You know, ice reduces inflammation, reduces swelling, can be helpful. So various levels of research there, mostly symptomatic, good for symptom control. Doesn't really change the overall trajectory.
I put off having my hip replaced for 2 years using acupuncture.
Yeah, and it can be helpful, and depending on what's causing most of your symptoms, there are ways to delay that, and that's great. Cortisone injections, most of us are probably pretty familiar with this, reduces inflammation. Usually you get them in series, maybe every 3 months. You have to go deep into the joint surface to release the corticosteroid, and can actually, long-term, can degrade the joint surface itself. So another thing to keep in mind. There is a time and a place for these treatments, but it's not always and all the time.
So you're saying like long-term wise injections?
And usually insurance and providers regulate that. They're not going to let you just get series of corticosteroid injections ongoing for years and years and years, typically. There's always exceptions, right? Chronic condition, someone that's not a candidate that for other health reasons to get a joint replacement that maybe really could benefit from one. Joint repair. So this is a really interesting part. Platelet-rich plasma. So they will draw your blood, centrifuge it down to platelets, and then re-inject it into a painful joint. That's because your platelets are paramount in reducing the inflammatory cascade. Typically not covered by insurance. 3 to 6 months of relief, can range anywhere from $500 to $2,000 a treatment, but has been successful, and there's some good research to support that process. In a similar vein, autologous conditioned serum. So they take your blood out once again, but this time they do some type of synthesis process to increase the proteins that fight inflammation and fight that inflammatory cascade. Does not regrow tissue. Symptom relief, though, has been seen, and series of injections are about 10 grand a session. But this is an option. It is an option. Stem cells injected into painful joints. The theory is that the stem cells will actually regenerate some of that cartilage, some of the joint tissue itself. Evidence is poor at this time. It makes sense on paper. We put these cells in that haven't decided what they're going to be yet. Maybe they'll regrow some tissue. FDA has not approved any of these options yet, still kind of in the experimental phase. Cartilage repair and restoration. So Another option is if you've got like a big cartilage deformity, like a big divot out of the joint surface, you can actually drill in and create some microfracturing in the exact area. The bleeding that occurs, because our bone is actually living, breathing tissue, blood's going to be released, it's going to clot, and eventually it will form a scar tissue, a type of cartilage that's more like a scar tissue. So not as nice and smooth as the joint surface that was there originally, but will help kind of fill in that divot. So that runs anywhere from 14 grand to 40 grand to have that done. That is also another option that has shown some success. And I've actually seen a couple people after these that have done well.
Do you know what the difference between like that cartilage repair versus cartilage transplant is?
So this would be just the drilling and the fracturing, but this would not be like putting actual cartilage tissue there in place. This is just causing some bleeding and allowing your body to create its own cartilage rather than putting cartilage tissue from another organism into your body to fill in the space. I don't. That's a good question. Okay. Long term. Whoop. Sorry about that. Dustin's going to take over. That's plenty of me talking.
And that's a good question too. And I think it's a consistent theme in the arthritis literature and just treatment is that we don't know. A lot of them are so new, like cartilage transplant versus the cartilage repair, or PRP, the plasma enriched, whatever that stands for. We usually say PRP. But those things are so new to be able to track those long-term outcomes. A lot of it's just guessing. So it's really hard to say. Also with surgeries as well. So we'll talk about joint replacements. These are more of the long-term interventions that we can do to hopefully get some results. So joint replacements are very, very common. Raise your hand if you have a joint replacement. All right. Which hip?
I've had my right hip replaced twice.
Right, twice. Okay. Was it a good experience?
It was easy, actually.
Yeah. And you were happy that you got it done?
Oh, yeah.
So classic hip replacement response there. If you ask someone if they've had knee replacement, you may hear mixed stories. However, joint replacements are pretty darn effective, especially with people that have significant amounts of pain over a significant period of time. So there's pros and cons, obviously, to when you're going under the knife. The big pros is typically pain is not going to be an issue. I mean, it will right after the surgery, but once you get through that recovery process, typically you don't have a lot of pain, which is great. It is typically a long-lasting fix, 15 to 25 years. There can be a lot of variability there, and a lot of the newer techniques have not been studied long enough to know how long some of these things will last or what kind of activity we can do around them. There's also the pros of looking at different types of surgery. So instead of maybe hacking off, both ends of your femur bone and your tibia, for example, for a knee replacement, what if we just hack off one side? What if we just change one side of that surface? So partial knee replacements are starting to become bigger. There's also some innovation in the hip in terms of hip osteoarthritis and hip resurfacing versus a full replacement. So what we basically found is, maybe we need to intervene a little bit less and see how those outcomes work out, and they're doing pretty well. However, like I said before, the long-term outcomes in terms of tracking these people over decades, we're just now really starting to see a lot of that research. So it's kind of the wild, wild west in a lot of ways. Cons, recovery can be tough. Knees are typically tougher than hips. We were talking before, was it your wife that had both knees replaced at the same time? That is tough. That is very tough. Typically, if someone would benefit from having both knees replaced, and he mentioned this, they'll do the first one, and then typically they won't do the second one after that first process. But there's a lot of variability in recovery process. We have some people that do awesome, they don't have any issues. Some people, it can be rather painful, but ultimately, when you're looking, a year out down the road, they're doing pretty well. A lot of their pain is gone.
PT afterwards is really really incredibly important. My wife, she had a PT who, home health care.
Awesome.
And, as my wife said at that time, more used to working with people who were in their 70s who were happy to be walking afterwards. My wife lost the ability because we didn't get
Right.
the painful, the full pain
Yeah.
benefit of the PT.
Yeah. Yeah. So PT is huge. Absolutely huge for these outcomes. Sometimes there may need to be a revision or another surgery. There's
I got metallosis.
What's that?
I got metallosis.
Yeah,
'Cause
all
I had
right.
metal on metal hip, and
Yeah.
they were recalled.
Yeah. So of the risk of surgery, that's one of them. Infection is another thing we want to think about as well. And then also there's a lot of variability in terms of capacity after surgery. So I would say almost always pain is going to be dramatically improved. However, function, there can be a lot of variability. So if someone is very active, for example, it's hard to say if they're going to reach their previous level of activity or what percentage of that. However, we're seeing, especially in this gym, a lot of pretty amazing things in terms of people that have had a hip replacement or a knee replacement, where they had physical therapy afterwards and their pain's gone, but they may not have had that range of motion or that function, or they perceived that they weren't able to do X, Y, and Z based on the fact that they had a joint replacement. And so we're seeing a lot of people that may have not been able to get to the ground and off the ground, for example, that are able to do that now. People that are running, people that are, squatting with a barbell, for example. And this is really showing Jeff and I, as physical therapists, that a lot of people are not getting a lot of guidance on what is acceptable activity after their surgery.
They tell you all kinds of stuff, like you can't do this, you can't do that.
Right.
I remember Sue was saying that, she couldn't, she was told not to squat, she was told not to cross her leg. Well,
Yeah, exactly. Yeah. We see this in joint replacements. We see this a lot with people that have heart attacks or bypass surgeries. You'll hear restrictions of don't lift more than 25 pounds. And some people will adhere to that for the rest of their lives, and that's no way to live, and there's not a ton of evidence to support that. So I would say in this gym, we're seeing a lot of people break norms and really see that they're able to handle a lot more than what they were told. But then also the Masters athlete group. So people like at the Kentucky Senior Games, for example, or the National Senior Games that have had some of these surgeries that are competing at a high level are showing that, yeah, you can still do some pretty amazing things even if you've had a joint replacement. So that area is continually growing, and we're seeing a lot of stereotypes being broken in here, which is really cool. Oftentimes, too, you'll see people that may be able to prevent having a surgery, even though it may be recommended. With some good physical therapy and some good strengthening, that can be prevented, too. So that's a good thing. But joint replacements, I'm not going to crap on them too much. They can be very useful and very helpful for the right individual, but we definitely don't want this to be the first line of attack, for sure. We want to be more conservative. Okay, so short-term interventions. Surgery can be a great long-term intervention, but we want to talk about the secret weapon, the thing that we all have control over to manage and hopefully improve arthritis and even prevent arthritis. The first one, and Jeff alluded to this before, getting brutally strong. This is Becky. Becky she wouldn't mind me saying this, but a 2-time breast cancer survivor, has MS as well, and she is absolutely crushing it here in the gym, getting very, very strong. The stronger, the stronger you get, the better off you're going to be related to arthritis. You combine movement and especially resistance training that you're able to do without flaring up your symptoms with nutrition, and you've got a secret weapon, a very potent attack to manage a lot of pain, a lot of inflammation, and a lot of those symptoms with arthritis. This topic right here is absolutely huge, the nutrition piece. What we're going to do is not cover that in depth today, but we're going to be emailing you all a resource provided by the Arthritis Foundation that has some pretty amazing recommendations for nutrition. We hear all kinds of stuff in terms of what's appropriate to eat. The big thing is we want to eat more plants. The biggest factor that you can change is just eat more real food. If you want to learn how to make really good food, I suggest you get Savoring Kentucky, amazing cookbook that Rona Roberts wrote. But if you eat what the recipes that Rona has written, you're going to be in a pretty good spot. But I'll be sending out a resource after the fact via email. So the big things, when you combine these two, getting very, very strong and eating properly, you can increase your odds to lose weight, you can reduce inflammation, you can support your joints. Let's talk a little bit more about that. Jeff alluded to this. The risk of knee OA is osteoarthritis increases 5 times when one is considered overweight or obese. So if you're going off BMI, Jeff has already increased his odds of knee OA 5 times. But this is a big deal. Weight can be an issue. Some surgeons won't operate until X number of pounds, which usually is kind of arbitrary. However, that really speaks to us that weight is a big issue. So moving is a great way to do that, obviously. Just from the calorie standpoint and exercise, but if you build a bigger engine, bigger muscles, that is going to increase your odds to be able to lose weight as well. So that's a big one. Also the inflammation piece. Nutrition can definitely impact inflammation. You can reduce inflammation, but you can also increase it as well based on what you eat. But also exercise as well. Movement is going to be very helpful. Jeff mentioned this in terms of when you look inside the joint space. Motion is lotion. Whenever we are able to move our joints throughout their full range of motion, that inflammation can be reduced. And you do that over time, that's going to be very, very helpful. So movement plus nutrition is big there. What's very interesting though is Jeff mentioned this, is in terms of some of those inflammatory markers. And when we say inflammation, that's a big umbrella term. There are particular values that you can track based on a blood test that like a primary care physician could look at. But a lot of these factors that may be elevated in some of these types of arthritis are things that we are also seeing in something like cardiovascular disease. So we're seeing an overall elevated level of these inflammatory markers, and we're seeing that manifest in some of these almost lifestyle-related diseases, and arthritis is starting to be thrown into that. Cardiovascular disease is one. Diabetes is another one that a lot of us are familiar with. So a lot of these things have a common link, and we can dramatically impact with lifestyle modification, with getting very strong, and with eating well. It's really interesting to see. The last, but certainly not least, is from the physics standpoint that Jeff mentioned, that the stronger you are, the better you are to support your joints. But we want our body to be strong enough to handle what we're asking it to do. And a lot of us ask our bodies to do more than what we may be capable of doing. This is how we want to think about it. Stave Off is a gym in Kingston, Ontario, ran by Christine and Nick Previtt, so they're good friends of ours. And they have a gym similar to this one. And they have the Stave Off model, and we are operating on this same model. Every gym really operates on this model. So on this axis here, we have physical ability. Right here, we have age, all right? So this is physical ability over a lifetime. So let's say one may have arthritis, that they are doing well. Then we start to see a type of decline with their physical ability. This red line represents kind of the minimum standard to be an independent human being. Our goal is we want to get you away from that red line. We want to increase capacity. We want to increase your physical ability. And the best way to do that is to train your muscles to be able to handle what your body needs to do, to get brutally strong. And the beautiful thing is that more is better. The stronger you are, the better off you are. So it's not like we need to get you only up to a certain point. The sky's the limit. We want to get you as strong as possible. More is better. And so what we say in the physical therapy world is right here, let's say if your physical capacity is very near this red line, you don't have a lot of reserve. There's not a lot of difference between your capacity and the demands of life. And ultimately, if you don't have a lot of reserve, you're not very resilient. We want you to be resilient. So the further away we can get you from the red line, the better. And we're doing this every day in this gym, and they're doing it right now next door. But I know a lot of you all that may have symptoms right now or have had arthritis know that it's not that easy. It's difficult to move when you're in pain. It can be very, very challenging to find something that's going to work for you. And so what we typically see is this cycle of arthritis where we may develop some type of pain. And then we move less to avoid some of those painful symptoms. And along with moving less, we may end up gaining weight, which ultimately can contribute more to the pain and the cycle of arthritis. It is a vicious cycle that can be very difficult to break, but we can break it. That's the big thing, is it can be broken and we can make a significant impact. So what we're going to talk about in practice is how we can break that cycle. And something that we leverage heavily here at Stronger Life is fitness with friends. All right? Fitness with friends. Not just fitness, but fitness with friends. There's a reason why Jeff and I are not practicing physical therapy right now and focusing solely on community-based group fitness programs, mainly serving older adults. If we can get people together and do things that are rather challenging, that are good for us, amazing things happen. And we can make a bigger impact oftentimes in here than what we may have made it in a one-on-one physical therapy session. When you get a group of people together, it is a beautiful thing. The accountability piece is absolutely huge, so consistency goes up through the roof. That's a big challenge in our world of physical therapy is we can be working with someone for 8 weeks, we get them going, we have them do all these exercises, and then we say, all right, your insurance stopped covering, or you got to a certain level, see ya. We discharge them and we give them a sheet of paper of way too many exercises probably, and then they're off on their own. We say, come back if you have a flare-up. And then if I checked in with them within a week or 2 weeks, probably not doing those programs, probably fell off the wagon, and that cycle can continue. When there's people involved in fitness with friends, people come more often and more regularly. Another piece, and a lot of the people in this room have experienced this, is you typically will push yourself a little bit harder when you're working out with others. Some of us are different. I know I've got friends that will, exercise alone, and that's okay, and they do fine. They do it consistently, and they push themselves. However, what I've learned about myself, many of my colleagues, and definitely working as a physical therapist, that's not the norm. A lot of people need accountability, and they need someone to push them a little bit. And the beautiful thing is, the harder you push yourself without flaring up your symptoms, the more results you're going to get. And so when we combine fitness with friends, we have more consistency, and we get better results, because people are going to push themselves. It's a beautiful thing. So let's stand up and let's go through some of these options that we're going to focus on that are going to allow many of us to start to get moving even in the presence of symptoms, of arthritis symptoms, which is a beautiful thing. All right.